I want to thank the invitation to participate. I have no disclosures. Well, if we know that stent implantation was developed to overcome the acute recoil and high restenosis rate in balloon angioplasty procedures, but resulted in development of chronic in-stent restenosis related to specific factors. Regarding patients, sometimes stents, sometimes lesions and procedural characteristics. So some factors are not modifiable, such as patient and lesion characteristics, but the procedural characteristic may be improved by better implantation technique and stent design. So drug-eluting stents are a novel approach in stent technology and designed with local drug delivery to inhibit intimal thickening, interfering with different pathways involved in the development of inflammation, migration, proliferation, and secretion of extracellular matrix. But the drug and the delivery vehicle must fulfill pharmacological and pharmacokinetic and mechanical requirements. Current successful drug-eluting stents require a polymer coating for the drug delivery. So endovascular options are increasingly recognized as primary treatments for lower extremity peripheral artery disease, inadequately responsive to non-invasive therapy. Options include balloon angioplasty and stent implantation, and newer technologies incorporate drug coating to prevent restenosis and reduce the need of reintervention. The replacement of intraluminal prosthesis, that is called in this time the stent, is the angioplasty area with the principle of serving as an internal structure to the artery wall to preserve the inside diameter and avoid post-angioplasty stenosis. So we have different generations of the stents. The first one significantly improved the treatment of coronary disease, decreasing the rates of revascularization. This was offset by high rates of late adverse events, driven primarily by stent thrombosis. So the research and design improvements of individual drug-eluting stents platform components led to the next generation devices with superior clinical safety and efficacy profiles, compared with bare metal stents and first-generation drug-eluting stents. So we have the first generation, that it's the intracoil on the wall stent. And then they became the laser cut loaded nitinol stents, like the SMART, the Everflex, or the Pulsar. And then came the interwoven stents and the biomimetics, like Supera, Biomimics 3D, and the drug-eluting stents like Silver PTX and Eluvia, and the cover stents or stent grafts like Biobon, and the extravascular and revascularization detour. So, like you know, we have a lot of stents. That means that we have a lot of data, and when we have a lot of data, we have a lot of things that we know and things that we don't know. So what we know about limitations of the stents? Well, we know that we have sometimes until 70% of recoil, dissections, restenosis, calcification, and the bloody dynamics. So what about dissections and recoil? In these two trials, the IMPACT and Levant, they saw it that when you make a drug-coated balloon angioplasty in long lesions, if you have a longer lesion, you are going to have a more bail-out stent. So what about restenosis? Well, with stents were necessary to improve acute results, but in the follow-up, they were provocative of restenosis. So clinical trials examined the several pharmaceutical agents, particularly sirolimus and paclitaxel, have demonstrated marked reduction of the restenosis and following stenting. So sirolimus is a natural macrocyclic lactone and paclitaxel is a cytotoxic agent against many tumors. So both compounds block cell cycle progression, and those inhibit smooth muscle cell proliferation. So the ideal drug to prevent restenosis must have an anti-proliferative and anti-migratory effect on smooth muscle cells, but on the other hand, must also enhance re-endotheliation in order to prevent late thrombosis. So additionally, it should be effectively inhibit the anti-inflammatory response, that is nowadays very important, for the response after balloon-induced arterial injury. So sirolimus in these two trials that we can see, it was one of the sirolimus eluting and the other one paclitaxel eluting groups. We see that paclitaxel significantly higher inflammatory score. So what about non-stent zones? Well, this concept increased the use of drug-coated balloons to avoid scaffolding. So what about the drug-eluting stents patency? Well, in this trial, we can see that in the follow-up of 2 years, suggests that sustained advantage of alluvia from avoiding target lesion revascularization, and initial hypoeconic halo assessment showed no difference in prevalence between the study arms, no flow with the halo, and no associated adverse events. What about classification? Well, we can say that it's the freedom from TLR. So we can see here that in 36 months, almost 87.6%, they were freedom of TLR. So severe calcification is defined like 1 centimeter both sides of the vessel, like in the picture. So about the fracture in this table, I put almost the 12-month follow-up of the fracture, and we can see that even that the silver PTX 12-month primary patency is almost the same that mimics 2. We can see that in the 12-month fracture, they are almost 0%. The treatment of femoral popliteal lesions with the biomimics 3D vascular stent system at the follow-up of two years, it was not a statistical difference in primary patency regardless the lesion location. So my resume is you have to choose the right patient. You have to choose for each patient the right technique. And how you are going to liberally the stent. It's very important, the vessel preparation, to predilate the atherectomy sometimes, the use of appropriate size stents, and the land and healthy proximal and distal zones, so you can use IVUS. So if we can see the evolution of the drug-eluting stents, we are better in restenosis, and we enhance the early and late thrombosis. But what about the mechanical performance? So, do we need new stents? If you see what are the complications of the stents, the recoil, dissections, restenosis, calcification, and blood dynamics, these are the limitations. So maybe we need something that could be bioabsorbable, new properties, maybe multi-drug eluting stents, or maybe we can find a new drug that could be perfectly mimetic, inert. So we have to think about out of the box. So maybe we could be a complete solution for the biological problem, not the mechanical chronic problem. So if we need new stents, the answer is yes. Thank you.